And for the last talk, I would like to invite Dr. Twinkle for his talk on Toric calculators.
Yeah, Dr. Sai, have you tried about the advanced monofocal like Irons mode or Clarion type lenses for the pediatric age group?
So we have used the Vivity in now about 8 eyes of children more than 13 years of age. It's too early, or it's too small a number to say too much about it. But I think these kind of lenses where there are no diffractive rings, definitely in older children are something worth considering. Yeah.
Okay, thank you. So we are now towards the end of our instruction course. This is the last talk, and I am going to talk about the Toric calculators. What is the posterior corneal astigmatism and how to measure it, and the nomograms regarding it, centered value, and IOL tilt factor. This is the recent study which has been published in IGO February 23. That was an evaluation of accuracy of the Toric calculators based on the total corneal refractive power. And they had studied about the 3 advanced Toric calculators like Abu Lafayette Toric calculator, Barrett Toric calculator, and Kent Toric calculator. But even though they are finding that the 0.6, nearly 6 to or 0.62 dioptric deficit in the Toric calculators. So there are still inaccuracies in the Toric calculations. So we are going to in details how these Toric calculators works and which are the still inaccuracies in this Toric calculator. So when we go for any Toric calculator, it usually have a 2 component. First component is a spherical component, and usually that spherical component we derive from our spherical formulas like our 3rd generation or advanced IOL power calculation formulas. Second component of Toric calculator is a keratometry, which gives us which model of the Toric implant you have to put and which is the axis of the implantation. So the inaccuracies which we have is the one is the surgical induced astigmatism calculation. Still we have some not definitive criteria for the calculation of it. Effect of posterior corneal astigmatism, which is variable in the different eyes. Influence of effective lens position on cylindrical power at the corneal plane, that has to be very well understood, and that has to be incorporated in the Toric calculators. Few things which is coming up is the optic disc tilt factor, and the new things which is coming up built in the Toric calculators is the postoperative IOL tilt factor. So we'll go in detail of each of them. Now SIA, you all of know that the SIA calculator which is available online, Dr. Warren Hill calculator, you have to put your data and you will give your SIA value. But still there is a problem in the SIA that the magnitude is not proper for the validation. Suppose that Dr. Shail is operating the patient and he getting the SIA, the same incision of 2.4 is 0.32, and I am operating the same 2.2, same site, I am getting the 3.8. So the SIA 0.38. So SIA is always a different magnitude in a different wide variations. Orientation is also not a consistent part. Median value is a less sensitive, particularly when there are outliers. So the thing has to be coming up is the centered value. This is most useful for the series of the cases. And now why the centered value has been come up? Because now we have a more advanced optical system, engineering systems, and we have very advanced supercomputers where we can go all theoretical trigonometric calculations. So this advancement gives us an idea about rather than putting in single angle plot of your results, put in a double angle plot and apply trigonometry on this vector analysis. And this vector analysis give you an idea about the centered value. So centered is an average of these vectors that represent the mean SIA value. And the 0.01 is considered as a 2.4 millimeter clear corneal incision. For 2.8, Dr. Douglas Koch is saying that it is 0.12 or 0.13. But if you want to get your own SIA centered value, you can go to ASCRS website. Astigmatism double angle plot is available over there. You can put your data and you can get your centered value. Second component is the effect of posterior corneal astigmatism. When Dr. Douglas Koch come with this article in 2012 that the standard keratometric and topographic machines are not giving the accurate net corneal astigmatism power. He found out there is a strong correlation between the front cornea and the back cornea. So the posterior corneal astigmatism has always some correlation with the anterior cornea, and also that correlation is also depends upon the with the rule astigmatism or against the rule astigmatism. So they find out that is the most of the posterior cornea works as a steep vertical, so it acts as a negative lens. So the posterior cornea acts as a negative lens, so it creates a positive net power plus power in the 180. So it creates against the rule astigmatism. So patient who have a with the rule astigmatism, they will have net effect of the decrease in the WTR, and patient of ATR will have increase in the ATR. So the next year Dr. Baylor come with a nomogram, and this nomogram we were using for the modification of the Toric implantation. So suppose we have a patient who have a WTR and a patient has a 3 diopter astigmatism, we were correcting on the Toric model. So we were decreasing the Toric model at that time. Suppose patient of against the rule astigmatism, we are going for the same model of the Toric calculator at that time. So the nomogram has good effectivity, good results as far as the power is concerned. But the meridian was not taken in consideration for that. For the meridian consideration, suppose you apply a nomogram, suppose the angular effect. This Barrett Toric nomogram applied a patient who have a WTR of 3 diopter at 70 degree. Actually it should go to 2.3 at the 70 degree. But suppose when you are measuring it, it is 2.3 at the 60 degree. So the meridian power was not taken care. So in 2016, Dr. Ferreira came with this article, and he found out that the posterior astigmatism will change the net power of the coronary astigmatism and axis of the net astigmatism. So nomograms were not taking, there's addressing the issue. So the algorithms and direct PCA measurements will do. So at that era in the 16-17, we have so many machines has been coming up which can measure the posterior corneal power in the astigmatism. So now we have two things, whether you have to estimate the corneal power or you have to calculate. Now this confusion has been cleared up by the certain studies has been conducted by the Dr. Ferreira, and 2018 he come with this study that the comparison between the Barrett, Abulafia, Koch, Panacea and the Phaco optics, all these 4 Toric calculators were calculated, and they found out there is the lowest astigmatism prediction error. But when they compare it with the estimation and the measuring, no one was the superior one. The same way, there is a certain studies that the different devices which are measuring the posterior corneal power, they have also not equal readings. So this is another study which shows that the significant difference between the total corneal power measurement by the optical biometry and the same way Simflux devices. So there are always so similarities are not there. There is not a university by different machines. So the estimation works very well in the most of the eyes, but outliers have a very worst outcome. And when we consider as a measurement, it works better for the outliers, but there is no gold standard to compare between the total astigmatism power of the cornea by different machines. Now third problem is the influence of effective lens position on cylindrical power at the corneal plane. Now all Toric calculators which are coming up, they have calculated either by using the fixed ratio or by using the estimated effective lens position. So what is the ratio? The fixed ratio is assumed as 1.45 to 1 from IOL plane to the corneal plane. But effective lens position has a very high influence on the toricity ratio. So suppose your patient has an average eye, then the toricity ratio is 1.45 to 1. But suppose patient has hyperopic eye, they may shift up to 1.2 to 1. Or suppose patient is a high myopia, it may shift from 1.75 to 1. So the variable toricity ratio is very important. So newer Toric calculators are coming up with the variable toricity ratio. So whatever the patient's axial length is there, this thing has been compensated by the newer Toric calculators. The same way, not the toricity ratio, but the steep cornea or flat cornea is also affected a lot. If suppose the patient has a very steep cornea or suppose a very flat cornea, the toricity ratio will be changed. So these are the few calculators which are considering the effective lens position toricity ratio. Like Bosch-Lomb and Hoya calculators, they do not have a fixed, they have a fixed ratio. So when you are operating the patient of a Hoya or Bosch-Lomb, there are high chances to have error when there are extreme of the eyes. So when you go for the implant for the Toric implantation with the high myopia or high hyperopia, be careful for this. And the few calculators are also considering the net corneal astigmatism part along with it. So which calculator one should use? A calculator which has a PCA automatically added as a third vector, a variable toricity ratio to be incorporated, calculations the spherical IOL power using the advanced formula. Like you use the Barrett Toric calculator, it will give the spherical power automatically. So those Toric calculators works very well and use a centered value to represent the surgical induced astigmatism. So this is the Alcon online Toric calculator which are also incorporating the PCA, posterior corneal astigmatism calculations by measurement or estimation. Both has been considered. This Barrett is also considering the measurement and estimations. Just Dr. Sonu has already elaborated about the Barrett Toric calculator. The same way, newer Toric calculator like a EVO formula calculator, they are also incorporating the way you can put the measured total corneal power. And Kent formula which has a estimated corneal power. So new Toric calculators are coming up and their works very well. And the last and the newer understanding about the optic disc tilt factor on the astigmatism part, certain investigations are going on for that. And another thing is the post-operative tilt factor. Because of the advancement in the topographic tool, we found out that what is the lens anatomy and where the IOL sits into the lens. So quantitative OCTs has been developed for that. And recently, Dr. Douglas Koch and Lee Wang has published a paper on this physiological IOL tilt factor, and they concluded very well that there is a significant mirror symmetry between the right eye and the left eye for the both crystalline lens tilt and the IOL tilt factor. There is a strong correlation in the tilt magnitude and direction between the preoperative lens and the postoperative IOL tilt factor. So in summary, instead of using a SIA value, use a centered value up to 2.4 mm incision 0.1, up to 2.8 mm 0.12. At present scenario, total corneal power estimation and measurement results are equivocal. Use Toric calculator which is incorporating centered value, PCA estimation, variable toricity ratio, and input the spherical IOL power calculation together. Our upcoming Toric calculators are TCP measurement values, and in future calculating tilt factor like Panacea has already incorporated the Toric tilt factor calculations. So the incoming Toric calculators are coming up which has a calculation of tilt factor. Thanks for your attention. Thank you all the speakers, and we are concluding the session. We invite the next session chair.
No, just 2 minutes more.
Any questions?
Yes. You had.
Yeah.
Can we have the mic to the audience who wants to ask the questions?
Yeah, you can.
Yeah, I have a question. In the swept source OCT, often we find an optional value, LT, lens thickness is missing. Any insight on why this message comes? Though the question is to Dr. Harshul, but he is not here, so if anybody of you would answer it.
Can you repeat the question, please?
Yes. Sometimes in IL Master 700, an optional value is missing. This is a reading that the machine gives in the printout, and that optional value is lens thickness. Could you provide an insight of why this LT is missing?
I have not used the IL Master, I am using the different machine.
You need to ask the size people in that case. Sorry.
Okay, it's fine.
Lady, you had a question. Please
Lady
go
has
to
a
the mic.
question.
Yeah.
Hello, everybody. Please, I have a question for our colleague who spoke about IOL calculation in pediatric patients. You said, sir, that you implanted IOL in a neonate 3 months of age, depending on axial length. What about keratometric reading? All we know, keratometric reading calculation is maturation up to 5-7 years. What about keratometric
So
reading?
no, definitely we do measure the keratometry under anesthesia with handheld keratometers. What I was trying to say is that in a certain case, if the eye is so small, or if you do not have access to a handheld keratometer to get an accurate reading, there are standard nomogram charts that as per the age, what should be the rough keratometry? You can incorporate that.
Roughly.
Yeah, roughly.
Thank you.